I'm realizing I'm not a public health scholar or a scholar in a policy school or a social work school. And so I'm surely going to miss many important things here. But wanted to sort of describe what I see as a bunch of work that is already happening. And think about it in this way, like what is the descriptive work that can show sort of how does the construction of the political economy affect health, and how does health systems and health status affect political economy? So that's descriptive work, and then I think there's the more constructive work, like how do we intervene? So clearly health is shaped by political and economic systems, right? Political economic systems and choices. So, we can, I think, tell parallel stories to the one I described about the way that shifts in the pharmaceutical industry help drive higher prices of medicines, and techniques like the trade agreements that made it difficult to, in fact, bring prices down, and see similar kinds of moves on often similar grounds, right? Elevating profit seeking because of its supposed efficiency throughout the healthcare system, right? So it does seem to me that even though we've gotten some expansions of healthcare, and I think that's really interesting and important over this time, thinking about your work, that we have a more intensive sort of profit motives. In part, the financialization literature is really, I think, helpful and going to help us sort of come to recognize this, that we've built more intensive profit seeking through the systems of health that we have, on the grounds that they're more efficient, or maybe that they're enabling choice. But in fact, part of the result has been more concentration of power in private hands, and transferring sort of power and control to people with more privilege, and away from others. So I think there's actually quite a lot of good work, both on the global side, like the commercial determinants of health. So how do trade agreements affect not just intellectual property, but also the prices of food, affect our ability to adapt to climate change. So I think there's sort of descriptive work, sort of how do you actually map the sort of policy changes that have an impact on health, and how do these institutions that are designing the economy impact health? But also thinking about the way changes that have broadly created more concentration in the economy, how do those affect health, right? So I have a student who's writing about the consolidation of the dialysis industry. And dialysis is a very, very concentrated, just a couple of players. And that has very, very significant impacts on patients. And so I think people are just starting to sort of map out, how does this process of consolidation and sort of monopolization work, not just in pharma, but how have we seen this happen in other industries? And of course, there's work similarly in healthcare, in the hospital context, right, showing that consolidation of hospitals, sort of trying to figure out sort of why is it happening, how is it happening, what are the implications for patients, for providers, and so forth. So I think there's also very interesting work being done, and that should be done, again, descriptively, sort of what's happening over the last couple of decades to show that even in areas where we do still have care being provided, and maybe even we're building certain kinds of healthcare provision, that we're building forms of it that really value tertiary care and intensive forms of medical care over more community-based care, sort of shutting down community-based hospitals and disadvantaging primary care to tertiary care and so forth. There's a terrific book called Redistributing the Poor, which tracks LA and the shift in LA of care from community hospitals into jail settings and into ERs, and sort of tries to tell a political economic story about, like, why did this happen? That has to do with the benefits that having a high-tech ER in a place like LA has for people of privilege, both inside the medical system and who use the ER, and basic decisions also about funding and about who's entitled to care that drove some of those shifts. So that's to say, those are a bunch of different, I think, places where people are already doing, and one could do more to sort of map out how changes that I want to associate with the sort of neoliberal, like, kind of idea of trying to prioritize efficiency, markets, and choice. What have they done? Because I think what we'll find, and already some work, important work is being done, is to show that the ostensible benefits are not actually what they were chalked up to be. And so I have a colleague who teaches at Penn Law School, Alison Hoffman, who does great work on the question of consumer choice in healthcare, and how little one should believe that consumer choice, for example, between insurance plans is doing a lot of work to sort of rationalize the market the way people in the Chicago school sort of suggested would happen. And anyone who's ever tried to choose between health plans probably has a very immediate sense of like what she's talking about. Right? So that kind of work, I think, sort of taking apart these sort of, and taking, what were the ideas? That choice was going to be really, like, is there choice? Is it working? And what's the result of it? What was the idea? We're going to make markets more efficient. Well, how have we gotten, like, only 3 dialysis companies that are trying to shed staff and cutting services and making things, making care worse, right? So I think that's one piece of it, but also, I mean, the social determinants of health literature is very profoundly, I think, valuable here, and one that, in fact, people working on political economy often look to. So they look to the literature on deaths of despair or on health equity to sort of point out that actually we have ways of sort of measuring how well our economy is doing that ought to really give us pause. It's not just about what people's incomes are, but actually what are the health effects that the kind of current ordering of our political economy has generated. We know that access to care is actually one of the less important drivers of health status, right? And that a lot of health is affected upstream by what Nancy Krieger calls eco-social determinants of disease. And we know that social democratic welfare states actually do tend to be associated with the best health outcomes and the lowest relative inequality. And so again, I think we can bring the same sort of set of research questions to, what have the changes in political economy that have led to more precarious work, to less stable housing, to, the very high rate of evictions that we have today, to extremely expensive housing, to the design of neighborhoods that lack all kinds of important infrastructure. How have those affected health, right? So there's a kind of a whole much broader, I think, descriptive project to ask about how the political economy has affected the social determinants of health. I think there's also lots of interesting stuff to ask about how health and the design of healthcare institutions itself shapes politics. Julia Lynch has a great kind of review in one of the annals of social science and about political science and political economy and health. And she has lots of great insights into and citations about the way that health status affects participation in politics. Not just the fairly evident part that people who die don't vote, which actually, if you try to sort of count up the implications of disparate mortality and health inequity on actual voting power, it's kind of wild, some of the studies you will find. But also, obviously, illness can lead to lack of ability to participate in politics. So that kind of work seems to me quite interesting in terms of linking the relationship between health and the construction of our politics and economy. I also think the kind of work about the way the design of our healthcare institutions, so for example, the tertiary care and specialty care institutions, the way those get built out and form constituencies for high-tech healthcare instead of community-based care, and move, concierge care, like those kinds of things are all really worth also trying to investigate and think about, like, and map their relationships to political economy. There's a book called Health Communism, which I recommend to all of you if you're interested in more sort of radical ideas about the construction of health. And they talk about what they call extractive abandonment, the process by which people who are generally, not well supported and who are marginalized are made profitable through systems like, let's say, the dialysis kind of enterprise. Or I have a colleague, Karen Tani, who's writing about the way that states sometimes have chosen to effectively manage Medicaid nursing home money to divert money from nursing homes and Medicaid patients to serve other kinds of, particularly red state phenomenon, to serve other kinds, that basically literally just take money out of Medicaid and use it for other parts of the state budget. Okay, so I want to wrap this up, but just say a little bit about the constructive agenda and how I think scholarship in health could contribute to sort of building more public and democratic sort of institutions in health and also more broadly in political economy. I'm happy to say more about the way I think this works in pharma. It's the thing I've thought most about. I think we really are at a moment where we could start to, in fact, better appreciate the role of the public sector in developing pharmaceuticals and expand it, and think about how entities like ARPA-H, which is already created, could actually act kind of like a developer and find medicines that may be being developed in labs at places like this that the private sector has often little interest in because they may not be very profitable, and actually develop the muscle and the expertise to try to develop new medicines, including for diseases that are neglected. One of the benefits of that would be you could price them at the cost of production. You don't need to make them very expensive and then build a price control system on top of them. So I'm interested also, I could talk more about building public insulin and public options for manufacturing and so forth. And also think we should be thinking about how to think about this same sort of what are the strategies and means by which one could make healthcare more public again. And that involves at least two things. It involves really close thought about policy design, both where do we ultimately want to get and then how do we get there? How do we build institutions? Because I think one of the things that I see working as I have on the pharmaceutical industry is that that we have a highly fragmented system, right? And that has really benefited, and I think to some degree has been deliberate on the part of entities that profit from the current system. It's very hard to find one place to go and say like, well, we'll just, we'll negotiate prices here. Well, there, there's Medicare and Medicaid and VA and then the private sector. It's very, very hard to sort of put the puzzle pieces back together. But I think we have to start to think about practical ways to try to both imagine better and more fully funded and better functioning public systems, more accountable public systems, and also thinking about how do we get there over time. Some of that I think will also would be very much benefited by thinking about how power is actually built politically, including thinking about the role of labor unions. I've done a little bit of work on community health workers as a kind of really exciting kind of labor force that can both provide really good services, but also unionize and advocate for lower tech versions of community-based healthcare. And so I think thinking about the intersection between forms of organized power and the kind of change that we want to see, and trying to map sort of, the really powerful work that was done to describe the benefits of community health workers just to the Medicaid bottom line that has really helped bring more resources to try to hire community health workers. And so that kind of work, as well as work that I think, so that kind of empirical work, sort of measuring the benefits of these and thinking about systems design are really quite important. But also, I think paying attention not just to that kind of policy work, but thinking in our own way, sort of like organizers. Like, where is the power? Where's the political power to actually make some of this research politically meaningful going to come from? And that's going to come from relationships and groups that are going to work together to either try to make some of these changes or not. And I've been talking for long enough, so I'll stop there and very much welcome questions on any of this and appreciate your ideas.
We do have a couple of questions online, but I think if people have questions now, we should ask them in the room.
Shall I just take the questions? Or?
Yes.
Yeah, great. Yeah. Okay, and well, if you wouldn't mind telling me your name too.
Oh yeah, so my name is Lauren Singh. I work at the Center for Global Health here at University of Chicago. Just a question about kind of the drug prices and the interplay with insurance companies. Because I feel like in some ways pharma companies kind of depend on people having insurance to be able to even pay for these prices. So is there any pushback from like, I might be just lack of knowledge in this area on my part, but is there any like pushback from insurance companies for the high prices, the inflation of drug prices?
Yeah. So there's I think there are some ways in which there's what happens is insurance companies contract with pharmacy benefit managers. So we're talking about the U.S. So one thing, if you work in global health, is you realize there isn't health insurance in a lot of places, and so there's not really a kind of health insurance system to push back. I guess one could ask about what's the structure of the health insurance system, and that's the question that I would want to ask, because if you have a public insurance system, you can actually very effectively push back against high prices. You can consolidate the purchasing power of your public system, and hopefully there's public servants saying, well, what's a fair amount to pay for this drug? And so most of the world that has, more universal forms of health insurance and that, has the resources, does it more like that. They basically control drug prices, and you can do it through an insurer. You can also do it through a board. There's a lot of ways to do it. But particularly if you have a single payer, you can say this is what, and then you have to be careful you do it well, right? You absolutely want to make sure that you pay enough if you're relying on the private sector to develop drugs. And I think for lots of reasons we should move towards more direct public development of drugs. But yes, so insurance absolutely could. But our insurance structure is highly fragmented, right? And part of what that means is that there is no one player that can actually get leverage over the market. And I think we've set up a kind of collision course also between the fact that patients are, want access to medicines, and they don't want the second best version. They want the best version. And so we have government mandates actually on insurance companies to provide. Now, it's very complicated how that system works, and they're not in any way absolute, but we have sort of more and more expectation that people have access to medicines, and then you have patents, right? And so you put those two together and you have monopolies and a mandate to cover. And as that starts to get really going, it's actually, you get recipes for high prices. So you have these things, these intermediaries, PBMs, they're supposed to try to negotiate better prices for the plans. There's a lot of problems. The FTC is actually opening new investigations into their structure because they don't actually seem to bring prices down very effectively. And of course, they take their own cut. So there's lots to say about, I think, why that isn't, that idea that maybe you'd have a counterparty who would be in a position to lower prices hasn't worked very well. Yeah.
Thanks, Amy. This was super interesting. I really appreciate all like laying out the whole ideas around the political economy of law and then thinking about how that applies to health. So I'm going to sneak in 2 questions. So some of what you said about like thinking about the social determinants of health and or just sort of how we think about measuring our economy, right? That we wouldn't just think about GDP and growth, but we'd actually think of like, mental health figures and death rates, et cetera. That to me sounds a lot like this movement around like the well-being society. And I think there's sort of 3 countries that have sort of made some progress on that. So I think there's 4 countries actually. They were all led by women, which is interesting. New Zealand, Scotland, Iceland, and there's a 4th that I'm forgetting. So just wondered if you had heard about this and what your thoughts are about if you guys have kind of connected to that movement of the well-being society. And then my second question is more about some of the last comments you made, which is sort of thinking about strategies and a means to make health more public. And so because in the US, the distinctions between public and private are so muddied, right? And so, and I confess that I'm kind of building a bit on my book here and the arguments I'm making, but like we have a very, very publicly funded system already, right? And so I guess one question I have back is like, should we be focusing on a better funded public system, I think you said, which certainly those which we call public systems like Medicaid and Medicare maybe should be better funded. I'm not sure. Medicare, I think, really a ton of waste. that said, should it, and then you said more accountable public systems. I mean, maybe we should be framing it that way, or should we be saying more accountable private systems because they're backed up by public funding, right? So like how do we think strategically about this, and is part of it kind of rethinking the whole framing of what we call public and private, right? And so anyway,
Yeah.
wondered if you had thoughts about that.
Wonderful questions. So I think we're in a moment where I think there's a lot of really interesting thinking about what public and private actually mean. And I think it is important to try to kind of develop more sort of debates about what we really mean by those terms. And so I guess what I would say is in the area that I know best, which is the pharma landscape, everything you're saying is absolutely correct. There is a ton of public money. It's not that there isn't public money. The problem is the layering of the public and private, in my view. And that has to do with the fact that we essentially kind of do a lot of the riskiest and most sort of foundational research in the public, and then we hand everything off to the private. And so we get the downsides of private for-profit management, which is insulin prices that go up 400% with no change in insulin. And we don't get the benefits of the public's investment. And so I'm attracted to more fully public models, by which I mean like California making its own insulin. Because I think that this highly fragmented system that we have, where we basically pay a lot publicly, but we hand off decision-making authority to private sector entities, brings us a lot of the downsides of the private sector without upsides. Now, that said, like what California has actually done is put public money in, and they've contracted with a nonprofit drug production company. You know, like, is that public? Is that private? Like, we can have a very interesting conversation there. And certainly in the short run, there's reasons to be pragmatic about what you can do. California doesn't have experience in building insulin production plants. They should absolutely work with somebody who does. But they have taken the decision to try to do it in a way that once this contract is up, maybe they would be in a position to actually build a public plant, right? And there's reasons I think that that's worth exploring. I think we need to take this in steps too, and sort of figure out how to rebuild and how far and how well it works to do this. So I'm less confident about what this would look like in just sort of the healthcare space, other than thinking as a little bit more of an outsider to healthcare, that we have a very similar problem, which is an enormous amount of public subsidy and then a lot of decision-making power that's handed off for ostensible benefits that unfortunately don't materialize. And so I think one could also make the narrative move that you're making and say we need more private accountability, but that would, I think, concede that there's virtues in the private sector that we ought to accede to, and we just need a little bit more accountability. And to be honest, I think that's certainly oversold and has been oversold. The Wellbeing Society stuff is very interesting. I haven't followed it closely, but it's very associated with things that I've been thinking about. Greg Gonzalez and I have a new essay that we've written about care and like what it would mean to sort of build an economy around conceptions of care as opposed to around conceptions of sort of productivity and efficiency. And that's drawing on sort of very old sort of materialist feminist work about social reproduction and the idea that the way we measure the economy, like, feminists have this great old like kind of joke that when a man marries his housekeeper, GDP goes down, because like work that's being done for no pay, which is not counted, isn't measured in things like GDP. And I think all of us thinking about COVID and the economic indicators at the time, you sort of could feel that, it's like, hey, we're doing this thing to actually try to make sure that the economy's still here and actually we can take care of one another. And yet somehow it looks like, we're not being productive. Somebody with like kids at home, I was like, well, I'm being very productive. It's just nobody's counting what I'm doing as productive. So I think there's a very deep sense in which health is a great space to go for sort of like what would another way to measure and value. And so I should look more closely at what sort of like what they're trying to do to implement that. There's other people who are trying to think about accounting for care and this sort of metrics, and because health is another space where we have a ton of data actually, and we can, I think, try to think about operationalizing some of this, these sort of ideas about well-being and making them more central. Yeah.
I'm Professor Gary Crown. A couple issues that come up. The insurance example is interesting because one of the challenges we have is that as a private actor, insurance companies don't have legitimacy to put pressure on prices. You know, if you go to our cancer center and we're charging $100,000 for a cancer treatment, and Cigna says, I don't want to pay that, the University of Chicago can, run an ad on TV and they can show this picture of this wonderful oncologist who's developed something and say, Cigna's denying this woman life-saving care. And the fact that we're overcharging for that is not a public thing. I do think that one question I was going to ask you about the COVID vaccine example, it seems to me that that's a success story in a lot of ways. Moderna and Pfizer really did a good job. But the way that we reward that is with high unit prices. And I wonder what you think of things like, if suppose we said to somebody, you develop a COVID vaccine, you have to sell it at marginal cost or license it for free,
Yeah.
but we're going to give you $50 billion. What do you think of, some Bill Gates and others have talked about? What do you think of those models?
Yeah, so I think those are very interesting. And so I've done some writing about, so economists call these like prize funds or prize models, where it says like, we'll give you a lot of money and then we kind of buy out your right to set prices. I think those are absolutely like, should be on the table in terms of thinking about like what could be a better system that still drives a lot of money into innovation and does not result in such high prices. I guess I think also though that we've done some things like this, like advanced market commitments. Some of the money to try to drive research into neglected diseases has worked this way. Although often it's kind of like the way the COVID vaccines work. First we give you the money and then we also let you set prices. And that's not successful. I don't think that's a good model. The way that I think the real advantages of putting up the public's money is like, and then we don't need the monopoly prices at the end of the day. And we haven't successfully implemented that version. I think we could do it with what's called push funding, sort of upfront funding, or we could do it with pull funding. I think there's like interesting debates to have about that. But I'd like to see also experiments with like just more public production itself, in part because I think there are some benefits to having more public expertise around things like drug manufacturing and drug development than we currently have, and more public authority to make development decisions. So I think that we should be talking about both of those things. On the insurance point, I think that's very right, and it gets to the point of like, we've built a very sort of powerful claim that people ought to have access to these medicines, and so it is hard to be in a position. And in fact, I'm not in favor of sort of imagining that like we should just sort of figure out how to put what happens with like insurance companies. What they want to do is lower prices in ways that advantage insurance companies and not necessarily that advantage patients. And they end up in the situation where they have to more or less they have to make the rationing move in order to bring the prices down. And so there's this threat of like, well, we're going to threat to cut off supply unless you bring the prices down. That's not a very politically popular model. And I don't think it's the model we have to be stuck with. So like the IRA is not that model. The IRA is like, we're going to bring your prices down. We're going to figure out what makes sense, and we're not going to threaten patients' access to it, because that's not very popular, and it's not actually what we want. So I think we have to figure out a better way than this current system, which is a little like, like a game of chicken, right? And like the patient is like somehow in the middle. Like that's not a healthy ecosystem to prioritize what we want from the perspective of public health. Yeah.
So I just started as a MPH or law student or Crown student, and I'm at your talk right now. I'm probably really invigorated by what you said. I'm thinking about how law, political economy can be applied to my work, assuming I'm somehow related to the health field. But I only have a couple of years here. I need to get my training. Like, what do you recommend someone like me? I mean, you're trained, my understanding is you have training in, philosophy, Marxist thought, feminist thought. You're obviously a law professor. You know, you have all these trainings, but I only have a couple of years of professional school. Like, what do I do to get a greater grounding in this new framework that's very appealing to me?
So, I mean, I think one thing, you and I were talking yesterday about going and taking classes in other schools and the fact that that is something that you often can do as a student. And I think all of us, sit in disciplines and it can appreciate the value of sort of interdisciplinary training. So I think one part is if you're moved by a set of ideas and you think they're important to your work, like go find classes about them somewhere else, assuming that your registrar will let you do that. So, but also I feel like a lot of my education did not come from classrooms, but came from being involved in these organizing efforts. So I think the other thing to do would be to figure out what moves you, like why? Why are you moved by this work? And then can you figure out how to work with organizations that are trying to address some of these issues? Now, that's not always easy. There isn't an obvious organization that's working on the financialization of health, right? And so, I think there are some limits to trying to sort of to go like kind of figure out how to link up with advocates. It's not always the best way to learn about every issue because advocates are busy working on what they're working on, and there isn't necessarily an advocacy commander on everything. But there are, like a lot of the work around public production medicines is being driven by groups like T1 International, which is, a volunteer base. They have a small staff, but they're an organization. You can find organizations that are working on these issues and work for them. I think the other thing is doing, I think, some of the work that you all are doing and connecting up, like when you find faculty who are working on these issues, try to do research for them, try to work with them, and develop an expertise in actually something, right? Like what I think is really productive now is that there are people both reading big, like going back and reading the big political economists of the past, or reading Smith and Marx, but like also like, how does Medicare Advantage really work? Like, and I think you actually want to do both, because I do not think it's enough to like revolution, we are going to like there's a thing called Medicare Advantage. If we made Medicare for all, it would probably become Medicare Advantage for all. And we have to understand, like, how do we understand how it's working? Can we persuade people it could be better? Could it be better? How would it be? It's like, I think it's also really important to start somewhere and to sort of not just remain in the sort of fascination of the sort of high level theory, but like get your hands dirty. And when you do that, I think you're gonna see and find out all kinds of interesting things like you guys have in the work on financialization. Like, oh my God, no one ever asked this question before. This is so cool. I can write a paper and then maybe I can go out and find a group that is interested in this work and will invite me to come talk and sort of build some of the inside-outside work that I think is so good for the soul and also good for your work. Yeah.
My name's Manu, student here. This is maybe like a touch more anecdotal, but I still think maybe would have some insights about this.
Could you speak up a little louder?
Yeah, of course. So like, I work in a translational research lab here. I think like 3 or 4 years ago, we received something like $250,000 to test a drug from a company. They basically just gave us a drug, we run experiments on the drug. This is something that you'll see fairly often. And I think you mentioned briefly sort of this idea of like academic entrepreneurial spirit and whatnot, things like D4T, which I think is like Stavity now. And I think there's certain directions that like academics are tugged in the sense that like you have, obviously you get R1, there's like one direction where you get R1 funding, you develop the drug, and then you start a company or something, or you patent it in order to make profit. There's also another direction where like pharmaceutical companies will sort of solicit experiments or work from academics. I mean, and like obviously I find both of these problematic, but I'm just curious, like, do you feel like, these attitudes sort of percolate through biomedical research a lot, where like, you have this idea that you're helping people, but you might as well make a profit while you're doing it. Is there any like role of like the average like university professor or someone who's doing translational or clinical trials or whatever to push back against those pharmaceutical influences and those sort of avenues to profit?
Yeah, that's a great question. I think So the organization that I helped to start when I was a student after this experience with Stavudine, Universities Allied for Essential Medicines, actually there's chapters in, around universities in the US today. And a lot of what they try to do is develop and advocate for policies that universities can adopt that would, in fact, impose conditions on these deals with companies and say, okay, like if we are going to, work with you to develop this compound, then we want to make sure that it's available in the low and middle income countries, or we want to make sure that you have a plan for, and if you don't, if it becomes unaffordable, then the rights change, and you're no longer the exclusive rights holder for that. So that's a place to go for a set of both organizing work that's going on, that's based on campuses, and has very much been, I think, driven by people interested in the health sciences, either in public health schools or, in clinical research, trying to figure out like how do we reestablish conditions by which our work feels like it really is in the public interest. And so there are a set of things that they've sort of put on the table that I think could be picked up and advocated for at the university level. And then it's a sort of also a portal to some bigger ideas like the ones we've been talking about. Like, well, maybe we also need to reinvigorate public funding so that when you are working on candidates in your lab, you can not only go to Pfizer, who will say to you, well, we're the only game in town, so I'm sorry, we won't accept your condition about affordability at the end of the day. I mean, you can say, well, I could either go to Pfizer or I could go to ARPA-H. And, let's see, maybe ARPA-H will develop this. And, so I think we do need some of the more structural work. And so, and that organization will do some of that advocacy work as well. But I think exploring some of that and then thinking about like what would it be like if organizations of doctors or clinical researchers actually started to kind of get in the game and advocate for these kinds of changes. I think that would be quite meaningful. And so, forms of public education, like that we could do this differently, that we don't have to assume that the current way of developing drugs, which leads to these highly unaffordable products, and not always to the best science, in fact. I think you will also find, maybe you have had this experience of things that got killed because, they weren't going to be profitable enough, or they were going to compete with an existing, the so-called killer acquisitions, where companies will buy up, new competitors essentially and say like, well, let's forget this new development because it's not going to be good for our bottom line. So I think we need to sort of educate each other and ourselves. And try to find, like, maybe we can do some work at the university or within our own, labs, but also think about how do we change bond policy in this direction.
Okay, I think that's about the time we have to end. So how about another round for our presenters?
Thank you.